My name is Surinder Ahuja, Medication Safety Officer. I would like to talk to you about timely administration of medicines and critical medicines. The outline is that I'll briefly touch on 7 rights of administration, then go on to share some incident data that was presented by the NPSA as part of a medication safety alert and the action they have requested. Then the local data and what were the reasons for those omissions of an audit recently done. I'd like to share about how to think criticality of a medicine and what we can do. 7 rights of administration for each patient to have right medication at the right dose, at the right time, via the right route, for the right reason, and that there is documentation at the end of it. Why is timeliness important? Timeliness is important because incident reports between September 2006 and June 2009 identified 27 deaths, 68 severe harms, and over 21,000 other patient safety incidents relating to omitted or delayed medicines. Of the 95 most serious incidents, 31 involved anti-infectives, 23 involved anticoagulants, and they considered that true rate of harm may be much higher, as events such as these are not often reported. This alert was reported in 2010. The actions they recommended was 1, develop a local list where timeliness is crucial. They must include anti-infectives, anticoagulants, insulin, resuscitation medicines, and medicines for Parkinson's disease, and other medicines identified locally. Action 2 was to have guidance on prescribing, supplying, and administering critical medicines, timeliness issues, and what to do when a medicine has been omitted or delayed. Action 3 was to have systems for the supply of critical medicines within and out of hours to minimize risks. Action 4 was to review incident reports, undertake an annual audit of omitted and delayed critical medicines, have improvement systems in place, and to include in the data information in the annual medication safety report. The last action was to make all staff aware that omissions or delays of critical medicines for inpatients or on discharge from hospital are patient safety incidents and should be reported via the incident reporting system. We have local data on serious incidents where there have been omissions. They involved clozapine, which required hospitalization, vitamin K, phytomenadione, there was bleeding, needed for bleeding, tinzaparin for pulmonary embolism, and carbamazole for condition where the route was not available. The data over the last 3 months shows we had 69 incidents reported that were of omissions and delays of medicines. When we did an audit on incidents involving medication omissions, reasons for those omissions were they were not prescribed because they were not listed in the summary care record. They were not prescribed on admission. Route of administration was not available. Lack of knowledge of the urgency. Lack of knowledge of medicines stock on the ward. Medicines not transferred from another ward. Non-stock items were ordered but not followed up. There was a lack of knowledge of pharmacy annotations. Pharmacy document what they supply. Nighttime doses were omitted on 2 nights. Night staff had not ordered the first night and they were not available for the next night. No awareness of used or dispensed supply or patient supply that was available. Lack of knowledge of approved names, e.g. it was prescribed macrogol. They didn't think they had it, but it was on the ward, it was Movicol. And that stock did not meet the needs of the patients on that ward. So in order to reduce those omissions, you can't remember every single critical item, but you need to look at this, think condition, then think what the medicine is for that condition. Also think emergencies, think stat doses, which require immediate administration. Think time critical doses, which are prescribed at times. For example, insulin and Parkinson's disease. Think dose criticals, which must be given on time or within 2 hours. In addition, for example, anaphylaxis, you need adrenaline to give on time. Epilepsy, anti-epileptics. If the patient has had an overdose, think of antidotes. If the patient has infection, antibiotics, antifungals, and antivirals are critical. Insulin needs to be given with meals or within 15 minutes of meals. Medicines for Parkinson's disease must be given on time. Steroids, whether high dose or long term, or for Addison's disease, they must be given, not omitted. And thrombosis, anticoagulants, whether prophylactic or treatment. What we need to reduce when prescribing in a timely manner. And if it's a stat dose of critical medicine, to inform nursing staff to administer it. If it's outside the ward around, nursing staff may not be aware of it. Pharmacy supply or advice is available during the working day as well as out of hours. They have a dashboard of requests of critical medicines which they review. There is a SOP for dispensing within 30 minutes of receiving the request. We deliver to the ward and we have advice for alternative formulations if patients cannot take the dose via the route prescribed. Out of hours, there's emergency cupboard, which stocks commonly needed medicines. Can borrow from the ward, from another ward. And there's on-call pharmacists who can dispense remotely and provide advice. From administration perspective, request prescribers to inform you if they're prescribing stat doses. Think criticality for every patient, whether the condition or the medicine. Be aware of what the medicines are stocked on your ward and order non-stock items in advance. Consider when you're ordering for each patient. Best time is immediately after you've seen the patient, you haven't been able to administer the dose. Order there and then, not after the ward round. And if you have ordered, follow up, especially critical medicine. Escalate if patient is refusing doses, especially of critical medicines. And if the prescribed route is, you're unable to give the dose via the prescribed route, then seek advice from pharmacy. Escalate if unable to manage dose administration in a timely manner. And from the patient safety point of view, report omissions and delays as patient safety incidents, learn from incidents, and suggest improvements that can be made